This is Dr. Michael Trainer. I have created this video to discuss anterior cervical discectomy infusion surgery. Anterior cervical discectomy infusion is a surgery that is performed through the front or anterior side of the neck. It is to remove a disc and place a spacer device with bone which will fuse or heal two bones or two vertebrae together. A plate and screws is then placed over the bones to hold the implants in place while they heal. This video is designed to discuss the risks and possible complications associated with anterior cervical discectomy infusion surgery. In addition, I will discuss frequently asked questions as well as instructions for patients undergoing the surgery and expectations that those patients may have with regard to recovery and results of surgery. With regard to the risks and complications, the first risk we discuss with any surgery is the risk of infection. The surgery does involve an incision along the front side of the neck, typically the right side. Anytime there is a cut in the skin, there is a risk for infection. The risk is extremely low, less than 1%. Patients will be given IV antibiotics during their surgery. This is all that is needed to prevent infection. Patients will not require at-home antibiotics following the surgery. The surgery is performed using sterile techniques and cleaning the area with appropriate antiseptics prior to the surgery. Blood loss is a very minimal risk during the surgery, and it is not a major concern. It is extraordinarily rare that a patient would require any type of blood transfusion with this surgery. Blood clots are also an extraordinarily rare occurrence with cervical spine surgery, and therefore patients do not require blood thinners of any sort following this surgery. The greatest and most common risk that we see with cervical surgery involves swelling. The surgery is performed with a general anesthesia. That involves placing a tube into the lungs, which will allow breathing to occur during the surgery. In addition, the surgery is performed in the front of the neck and retractors are placed. The combination of the tube in the trachea as well as the retractors in the surgery is what leads to swelling. Swelling, if it is significant, can result in some difficulty with swallowing. This is referred to as dysphagia. In addition, some patients may feel slight shortness of breath because of swelling. As a result, we will provide recommendations to decrease the swelling and hopefully prevent the significant swelling that could occur. Patients will be given a prescription for prednisone. Prednisone is a steroid that will decrease swelling. It is not a narcotic, it is not addictive, it is not habit-forming. Patients should take the prednisone as prescribed for 5 days following the surgery. It is a tapering dose, which means the patient will take 3 pills the first day, 3 pills the second day, 2 pills, 1 pill, 1 pill, but all instructions will be written for the patient. In addition, the patient will be given a prescription for pain medication that can be taken as needed, and also typically a muscle relaxant. That is also a medication that can be taken as needed. Patients are instructed to perform regular icing to decrease swelling. Patients should apply ice packs to the front of the neck and the back of the neck, and the ice packs should be applied for 20 minutes every 2 to 3 hours. The patients do not need to wake up at night to apply the ice packs, but they should be applied every 2 to 3 hours while the patient is awake. 20 minutes on the front and the back of the neck every 2 to 3 hours is appropriate for 5 to 7 days following the surgery. Patients are also instructed to eat a soft diet if they experience swallowing difficulty. Diet should include things like smoothies or milkshakes, especially cold items, because the cold items will also decrease swelling from the inside. In addition, we recommend eating puddings or yogurts, scrambled eggs, oatmeal, foods that are soft in consistency. Liquids and solid foods seem to be more difficult for patients to swallow. If patients do not experience swallowing difficulties, they can resume a regular diet as tolerated. Other risks we discuss with cervical surgery in terms of a fusion surgery. A fusion is fusing two bones together where the bone has to heal. If a fusion does not heal, then that is called a fusion non-union. If the fusion does not heal, the patient will require additional surgery. Again, implants are placed between the vertebrae that are to be fused, and a plate and screws is placed to hold the implants in place. The plate and screws is designed to hold the implants and hold the bone in place while it heals. A fusion typically takes 6 months to heal. Once the bone has healed, the plate and screws does not have any function any longer. Technically, the plate and screws could then be removed, but it is not usually removed because it would require additional cervical spine surgery. When the patient is seen following the surgery, x-rays are taken to make sure there is no failure of the fusion to heal or any complications with the implants. If a screw or a plate breaks or the fusion construct changes, then that would be something that would need to be addressed. This is not a complication that occurs with any frequency. Much less than 1% of patients could experience this complication. Other risks we discuss include the spinal cord and the spinal nerves. Anytime a surgery is performed around the spinal cord or the spinal nerves, there is technically a risk of injury, including paralysis. I have not ever had a patient experience paralysis following a cervical surgery, but it is certainly something that is a risk. In order to take all precautions during the surgery, patients undergo what is called intraoperative nerve monitoring. What that means is once the patient is under the general anesthesia, a nerve monitoring technician will place needle probes from the skull to the toes. Those needles will be hooked up to an apparatus that monitors spinal cord and nerve function. That way, during the surgery, I will be able to know if there are any changes with regard to neurologic function. This is a very safe way to monitor the patient's nerve function throughout the procedure. Most patients are having the surgery for combinations of neck pain and neurologic symptoms, particularly into the arms. The symptoms may be numbness or tingling or weakness. The surgery is designed to help improve those symptoms as best as possible. Unfortunately, oftentimes those symptoms will not be completely eliminated, but hopefully they will be improved to a greater degree than any other options that the patient has attempted prior to surgery. The surgery typically takes about 1 hour per level of fusion, meaning if the patient is having surgery, for example, on the C5 and the C6 vertebrae, that is 1 level of surgery. If the patient is having surgery on C5, 6, and C6, 7, that is 2 levels of surgery, and each level typically increases the surgery time by 45 minutes to 1 hour. Most oftentimes the incision is to the right side in a straight line in line with the skin creases. If a patient has a 3 or 4 level surgery, oftentimes the incision will be longer and more at an oblique angle. The incision is closed with dissolvable sutures, so there are no sutures that need to be removed. On the morning of the surgery, I will see the patient and any family members or friends that are with the patient. I will obtain appropriate contact information so I can contact family members when the surgery is complete. Again, most patients who undergo this surgery will be discharged the day of the surgery. In rare instances, if a patient does require staying overnight, that can be accomplished, but it is very rare for patients to require an overnight stay, and it would not typically be greater than an overnight stay following this surgery. Patients will be notified the night before their surgery by one of my surgical schedulers regarding the time to show up for the surgery and the location. Patients should not eat or drink after midnight the night before their surgery. There is one exception. Patients who take a blood pressure medication in the morning should take that medication with a small sip of water. All other medications should be held, and patients should not eat or drink anything after midnight the night before surgery. This includes throat lozenges, gum, water, coffee, any type of food. So patients should not have anything to eat or drink midnight the night before surgery. If a patient is having surgery on a Monday, they will be called the Friday before surgery to give them the instructions in terms of the location as well as the time to show up. I will typically see patients 7 to 10 days prior to the surgery in a preoperative visit. Patients should schedule a follow-up appointment for after the surgery at approximately 2 weeks after the surgery, and that appointment can be scheduled at the preoperative visit. In terms of restrictions, we do not require collars after the surgery, at least initially. If a collar is required, it will typically be given to the patient at the 2-week follow-up appointment. Patients should avoid excessive neck bending, twisting, or lifting following the surgery. Patients should not lift more than 15 pounds. Patients are allowed to begin light cardiovascular activity the day following the surgery. This should include walking. Patients can walk outside or walk on a treadmill. Patients could utilize a stationary bike or an elliptical trainer. Patients should not jog or run and should not do excessive activity. The patients are allowed to shower the day following their surgery. Typically, they will have a clear dressing with a gauze underneath the clear dressing. There are steri-strips below the gauze. Patients should keep the dressing on the first day as it is waterproof and they can shower. The second day after surgery, patients should remove the outer adhesive and remove the gauze, but keep the steri-strips intact. Patients can get the steri-strips wet with their shower. Patients should make sure that the wound is completely dry following their daily shower and apply a clean, dry dressing. Patients should not apply bacitracin, ointments, or anything other than a clean, dry dressing following their daily shower. Patients should make sure that the dressing is completely dry, because if the steri-strips are still wet, they may start to ooze, and patients will be concerned that there is infection. So either allow the wound to completely air dry prior to performing or placing the dressing, or use a blow dryer on a cool setting for a couple of minutes to dry the wound. The patients should then place the dressing once a day after their daily shower. Again, patients will follow up in the office at approximately 2 weeks following the surgery, at which point x-rays will be obtained. The patients are then typically referred for outpatient physical therapy, which will begin at 3 to 6 weeks following surgery. Patients will be seen at 6 weeks following surgery, at 12 weeks following surgery, and at 6 months following surgery. Most patients are back to full unrestricted activity levels at 3 months following surgery, but some patients may reach that level of activity at 6 weeks following surgery. At 6 months, the fusion should be healed internally. Patients may not have complete elimination of all symptoms following the surgery, but hopefully they have a significant improvement and are able to achieve better results than what they were able to achieve with non-surgical measures. At 6 months, the fusion is typically healed. Patients are often seen one more time at 1 year following their surgery. Hopefully, this answers many questions involved with anterior cervical discectomy and fusion surgery. Patients are encouraged to review the present video by going to our website at AOSMLV.com. Again, AOSMLV.com. Patients can then go to the link with medical providers or medical team, and they can click on Dr. Michael Trainer and look for the anterior cervical discectomy and fusion video. Thank you.